All right, so chatting with Sol yeah, talking, it's great that we can obviously do this, and I'll be really interested to hear everyone's thoughts. And as much as we can, I'd love it to be more of a collaboration rather than me just doing a lecture, because obviously I'm a physio and not a teacher. So by all means, chat away with me. But yeah, so what we'll run through is a bit of a hip pain case study. So we'll chat about like the way that we go about as a physio to diagnose, and then what we do in our assessment to then lead to our treatment. So yeah, so hopefully you'll get some value, and I'll be really interested to hear your takes on it and how we differ and how we're the same as well. Because yeah, obviously we've really enjoyed working collaboratively with you guys over the last couple of years, and really value your input and collaboration. So obviously this is what you see from across your clinic. So yeah, so I thought I'd just kind of talk a little bit about who we are, because that kind of ties into our philosophy of treatment and how we go about things. So yeah, pretty much we just want to help people live unimpeded lives and making everyone healthier and with stronger bodies, so that they can take away the limits in their life and yeah, find their inner athlete, whether they're a grandma or whether they are a teenage athlete or so forth. So here's my crazy bunch. So I've got 3 kids, and yeah, I've been in private practice for probably, I think, about 15 or 16 years now. So that's numbers starting to get a little bit scary. But obviously, yeah, I was noticing that the way that we treat our athletes to treat our everyday mums and dads clients, there was a bit of a discrepancy. And so the way that we kind of have evolved is to really kind of treat everyone like an athlete in a way, in terms of, well, when you're returning an athlete to sport, you obviously need to look at what they need to be able to do and where they're at, and then reverse engineer it back so that we can return them safely and effectively, and you know, not just so they don't get injured, but so that they can actually perform. So so yeah, so obviously that's kind of how we've, you know, developed our kind of philosophies in that perspective. So acute injury management and diagnosis, and then really we use the Pilates to improve movement optimization, and then we just start loading people up. And I think, you know, physio has a bit of a reputation for, you know, giving homework, and, you know, we love our TheraBands and all of that sort of stuff, but you can only go so far. You know, 3 sets of 10, as we all hate to prescribe. I think I'll never prescribe 3 sets of 10, even if it's valid. I'll always do 12, just to make a point. But you know, like, it's not enough, and it's not enough for the loads of life. So then that's where we integrate strength and conditioning, and increase their load tolerance, so that we can return them back to running, or, you know, even if we're talking about your mum or your grandparent, like they're still lifting a kid that might weigh 16 kilos, so they're still squatting 16 kilos. So just looking at it from that perspective of what's required in the task. Yeah, so here's our ugly mugs, our team. So yeah, so anyway, so I thought we'd get straight into it. So hip and groin and lower back, and it's all, like, I don't know, it's all a bit messy a lot of the time. I don't know how you guys feel. It's never as clear cut as what the textbooks say. So obviously we've got the Doha Agreement about how to classify hip and groin pain. And so we've obviously got abdominal related, which is, you know, I don't see a lot of. Obviously footy physios would see a fair bit more of. We've got our hip related hip pain. We've got our pubic related hip pain or groin pain, adductor related, and hip flexor related. And then obviously based on all of those sort of diagnostic sources of pain, we need to treat accordingly. So in terms of, looking at a case with someone with hip or groin pain, or like anterior hip pain, we're pretty much mainly talking about, you obviously need to clear for red flags that we all do, and then clear the lumbar spine and SIJ, and then we can go about going, well, what are the structures, or what's the main areas that's contributing to your groin or anterior hip pain. And so obviously we've got the adductor related, pubic related, and as I said, and so forth. And then like potential imaging, not that we're going to be imaging everyone under the sun, and then just obviously helps to confirm diagnoses if we see that that is going to help with a prognostic conversation or change our management moving forward. So yeah, and then obviously referring on where we need for either those imaging or, red flags. So in terms of red flags, I think it's important to keep in the back of our minds. So obviously anyone with a history of cancer, or anyone with an immediate family history of cancer, especially around the hip groin area, like, we need to be mindful, because you can get some, nasty metastases around the pelvis, and some, other sort of gynecological issues can refer into the hip and pelvis that we need to be aware of. So I'll often ask, obviously, around history of cancer, obviously pain that's unrelenting, and all of the, you've got your weight loss or weight gain that's unexplainable, night pain that's unrelenting, all of those sort of things. And then obviously screening the lower back, we'll probably get to it later, but we know that if we can treat the back or do repetitive movements of the back, and that starts to improve the groin pain, well, then we know that it's more of a source from the back, and we can start to rule that in. So subjectively, what I'll often be talking to the patient about is obviously you get a sense of their age and gender, because that's obviously going to start to, dictate where you're going to go in terms of your pathology. So generally over 35, you start to think about OA. Meanwhile, I'm sure we've all seen hip OA with younger people, a lot younger. I think my youngest hip replacement was 21 that came through the doors, or it was pre-hip replacement, but she needed it. So yeah, so we can't obviously rule it out. But when we're dealing with that anterior hip pain, we want to think about what they're doing from an activity perspective. So if they're playing a kicking sport, then it's going to be more likely to be affected. And then, so I'm just moving that out of the way. So then, long distance runners, and you're kind of more thinking about your overload injuries, and keeping in the back of your mind about, has there been a real spike in load, and am I dealing with a stressor of the neck of femur, or probably more commonly, obviously, your lateral gluteal tenopathology. And then obviously if it's a teenage sporty history, you might be thinking a little bit more a relationship with a CAM, and then other significant findings of like pain at rest or pain at night. So we're thinking more like your synovitis, and then catching, clicking, giving way. We're thinking, is there something wrong with the labrum? But then at the same time, we want to make sure you can still get that clicky, flicky feeling if it's your like psoas being overloaded and that sort of thing. So so that's kind of where we're at. Do you guys look at many other things feel free to take yourselves off mute and go nuts. Not really.
That covers it for mine.
Yeah. And like, I think, you know, we all like to think about things going in a straight line, and it's like, you know, if A plus B equals C, well, then we're going in a straight direction. But unfortunately, you know, the more experience we get, we look for patterns, obviously, and it'd be nice if it looked like our little, you know, blue circle here, but often it's a bit of a complex interwoven pattern like the one on the right. But, you know, certain things can definitely help us out. So, you know, if the patient walks in with a limp, 7 times more likely it's going to be the hip rather than the spine. Pain in the groin or anterior hip, it's 7 times more likely to be hip than spine. Reduced IR is a really, really common one, and we're going to be a lot more suspected of hip than spine pathology. And then like I said earlier, if we make no change with repeated lumbar movements, it's got a really high sensitivity of ruling out this lumbar spine. Same with a negative straight leg raise. So we can obviously start to rule out some nasty lumbar spine pathology. And then, yeah, no pain over SIJ, we're pretty happy to rule that out. And interestingly, 100% of people that were diagnosed with FAI had anterior hip pain. So the key elements to assisting us in our diagnosis, obviously, is pain location. So, you know, I think, you know, I'll often notice that different pathologies will, obviously, people will say different things. So, you know, that classic C sign, like they grab their hip, you know, you kind of go, okay, I'm going to be, you know, going real hunting around the hip and looking to see what I can find. And then, you know, we've got this nice little picture here about all of the different areas that we can really kind of hunt around and see about whether these structures are painful. So really getting close in it with your palpation skills. And obviously, like, these pictures are pretty, you know, there's no nice draping that's happening here. And I think we can all probably do a much better job than these pictures. But, you know, just being really confident in your palpation skills, and, you know, using towels and getting the patient to, you know, clear themselves. So I'll often just say, you know, just put your hands over your groin, please. And just, you know, if it's a male, I'll just say, and just pull yourself to the side. So, you know, I don't touch anything that you don't want me to. And same with women too. I'll often do the same thing. And you just say it really clearly and bluntly, and it's not a big issue, but it's a much more big issue if you kind of, you know, 1, not palpating because you're a little bit nervous, or 2, you're just not getting into the right spot, or 3, you know, causing an issue, touching something that you don't want to be anywhere close to. So yeah, so doing that, I'm sure that you guys are all completely across all of that sort of stuff. But if I'm not sure, I'll just get them to do a resisted, you know, say like psoas or adductor, just a resisted adductor movement, and then I'll feel adductor longus, and then just work my way up until I feel the attachment on the pubic bone. And then same with, you know, feeling the pubis. I'm sure you guys are across it and probably better at it than us, because you guys do lots of pelvic work, from my understanding. So yeah, but really, like, anterior hip pain, we're really kind of zeroing in on hip joint pathology or findings. The tests that we use routinely, so FADA, so it's really a highly sensitive test. So it's great at going that if it's positive, it tells us that there's something wrong with the hip, and that's all that it tells us. So just bringing the hip into flexion, adduction, and then adding internal rotation. And if that is bringing on their pain, well, then that's positive. And if it doesn't, well, then it's really sensitive at ruling the hip joint out. And then obviously if there's some restriction in IR at 90, we're kind of thinking that it could be OA or, you know, some joint or capsule issue. And it's just really good to obviously compare left to right and see if there's a big discrepancy, and same with external rotation, comparing left to right, but then also looking at the total IR and ER range together, because sometimes you'll have someone with a really high amount of internal rotation range and then not much external rotation range, but in total they're looking pretty good. And then yeah, so it's kind of good to have a bit more of a big picture view from that. And then obviously adductor squeeze, if it is you know, positive, it's got a high specificity rate of you know, that the adductor is part of the problem. However, the sensitivity is quite low, so you know, take it with a grain of salt. There are high risk of false negatives. And then yeah, resisted hip flexion, you know, if we're trying to hunt around for psoas, we want to get the hip above 90, and then that kind of inhibits like your other hip flexors and really hones in on psoas there. So that's a way of ruling in that as a bit of a problem area. And then obviously like your inguinal and abdo, sorry, that's my typo late night last night. So yeah, so you resisted sit up and you know, cough and sneeze and all that sort of stuff. And then obviously our palpation skills are going to tell us a lot. And then we want to look at some strength testing. So we've got some handheld dynos, and this is a way that we work out where some deficits are. So we know that in FAI, all muscle groups are going to be down, and we know that like post-surgically, adductors and extensors are going to be down as well. And then, you know, just in general, and this is a common thing that we see, and especially with women being a little bit more prone to your lateral glute tenopathologies, we know that abductors can often be a little bit more down in women than in men. So yeah, so and then in regards to, you know, it's all very well and good to have numbers, but what is it that we're expecting? But yeah, so like, you know, for example, like your abduction adduction ratios, we'd like it to be a 1-to-1 in a normal population. And really like what's been reported from specialists is that they like, you know, 150 newtons, so that they can really push and pull 15 kilos in both adduction and abduction. But obviously soccer players and, you know, those sort of athletes, you're going to have a higher adduction strength than abduction. But again, just from a clinical perspective, especially when we're dealing with, you know, a painful joint or a painful area, anything greater than a 10% variance from left to right is going to be clinically significant. And we need to kind of hone in and look at that a little bit further. So all of this is just a little bit of theory. So sorry that it's probably a bit dry and very much lecture-like. So, and I said that I wasn't going to lecture, but yeah, we'll apply it to a bit of a case in a minute and get it slightly more practical. But yeah, so impairments from a strength perspective, and then impairments from a range of motion perspective. Often with OA, we're seeing decrease in flexion range and also IR range. And then, yeah, if we're down in IR, we're kind of thinking more bony impingement or capsular stiffness. And then, but sometimes, like, you know, if it's not like really significant, you might clean up the back of the hip joint with a bit of soft tissue work, and then see if that can really improve your flexion internal rotation. And then that, again, with that little mini treatment, it's demonstrating that that's a important area to focus on with your treatment. And then obviously with the Faber, just seeing what the external rotation range is. So obviously either up in flexion, abduction, and external rotation, and seeing if they're getting pinched up at the back of the hip at all. So sometimes that can be due to a little bit of tight adductors. And then the other one that I like to use is just like it's a bit hard if you're in the clinic, obviously you'd be able to see me, but just put the ankle on the knee and just let the on the opposite knee rather, and just let the knee drop out, and then that gives you a really clear indication of where you're at with the distance from the knee to the bed, and that's a really easy way to eyeball, and then obviously do your mini treatment and see if you can improve that. And then from a functional perspective, what we are looking at is their trunk function, because we know that obviously being able to control that lumbopelvic area is going to change the orientation of the hip joint. So often we'll find, and this is probably something that you guys see a lot of, I would assume, is just, like that, increase lordosis, or that anterior tilt increases that internal rotation of the hip joint, and then you're more likely to get some impingement. If you're able to improve that trunk control, then you can often tidy up a little bit of some symptomatic impingement. But yeah, and then a nice little, obviously, functional test to kind of really hone in on if there's a problem or not is a side bridge test. And if you can hold that for 30 seconds. Meanwhile, I reckon I'd struggle. I'm pretty rubbish when it comes to side bridges. But just functionally, I'm always just having a look at them and seeing what their double leg squat's like. Often you'll really pick up some valgus. And then sometimes, like, the deeper they go, then they'll use a trunk strategy, and they'll just kind of flex forward at the pelvis, and that really demonstrating that they just don't have good hip extensor strength, or quad strength. And then if the double leg is okay, then you go to single leg, and that's where you'll often really identify some real deficits, and they can often have the lateral pelvic drop, and then medial collapse with the increased valgus with internal rotation of the femur, and then it goes down the chain, and often that goes hand in hand with some pronation and that sort of stuff, and it just all depends on how severe their biomechanic impairments possibly are. And then often just like doing a single leg heel rise, again, like they'll probably hitch up through the hip, and you see all these weird and wonderful ways that they move just to try and compensate for some weakness through the posterior chain. And then a hop test. I don't routinely hop too many of my patients. That have to be a pretty active, fit individual. But again, it's a really provocative test in the way that it really highlights some impairments with the way that they're moving. So often they'll really wind themselves up and rotate just to be able to get some power going. And then that gives you an indication of, well, is probably a pretty big contributing factor of why you've got some pain and dysfunction at the moment. And then the big question is whether we need to do anything from an imaging perspective. I guess I think it's all been drilled into us that we only ever image to confirm a diagnosis, not to find a diagnosis. And then again, even if we are wanting to confirm a diagnosis, we kind of still need to ask ourselves, like, so what? Is it going to change my management? Do I need to refer on? Or, sometimes, especially with these sort of, hip cases, like if they're pretty self-explanatory and they're making some gains early on, I won't bother. meanwhile, we'll get to the actual recommendations, which they actually do say that to get a definitive diagnosis of FAI, you need to have imaging. But just from a prognostic indicator, I think it's a good thing to have a talk with the patient about. You do have these findings on your x-ray, and that indicates X, Y, and Z. And we know that you'll cope really quite well, but we do need to implement some rehab to account for these changes or these findings. But yeah, we're all obviously, I'm sure, on board with kind of de-escalating and de-threatening findings on MRIs and X-rays, and that could be a whole other conversation. But when we're imaging for hips, I'll always ask for, you know, AP pelvis and the done view. The done view is obviously what we use to pick up the alpha angles for FAI. And then the false profile view. So that's probably a bit more for your dysplastic hip, but I'll still ask for it. And then, you know, this is kind of based on what we were just talking about, like, you know, the purpose of imaging and what we're going to find. And these values just demonstrate how common findings are on MRIs. So like our MRIs are just getting so good. They're just picking up everything and they're just so sensitive. So, you know, a labral tear, 65% of dancers are going to have a labral tear, and 57% of an athletic population will have one, and then 54% of asymptomatic population will have it. So if we're going down the imaging pathway, you know, I think it's quite a good thing to have that conversation going. You know, you've got a 1 in 2 chance of us finding a label tear as a finding. And I'm trying these days to stay away from saying, you know, a label pathology or a label tear, like, or well, I'll probably say tear, but you know, talking to them more about image findings, and kind of like, especially for lumbar spine and that sort of stuff, you know, liking it to, we'll generally find some age appropriate changes, just like wrinkles on your face. We might find some degeneration in the disc or some decreased disc height or those sort of things. You know, it's just you know, they're kind of as useful as telling your grandmother that she has wrinkles on her face. So yeah, so, and then cartilage deficits, again, this is probably like less in your atraumatic or asymptomatic population, but dancers and athletes obviously have more, and we would assume that probably more like your higher contact AFL population would be higher again. So this athletic population was more your basketballers, so your non-contact, and then ligamentous teres. So again, like 1 in 5 dancers are going to have a lig teres tear. Go from there. So, you know, I think it's just important to understand the prevalence of what we're going to find on MRI and what we're going to do about it, if anything. But I think, you know, it's like synovitis and those sort of things. You know, if you've got a inflamed, angry joint, I think that's where we're going to need to be incorporating a multidisciplinary approach and getting the sports docs involved to calm down the joint, so that then you know, your treatment can be a little bit more effective. So yeah, so as of like, to get the diagnosis of FAI, we want positive image findings. So they were saying, you know, a positive done view, like alpha angle. They need to have symptoms and they need to have signs. So symptoms are what the patient's reporting to us. So, you know, pain with sitting for too long, pain with walking, pain with running, and that, you know, anterior hip pain. And then our signs are obviously our, you know, positive, our special tests, and then our physical impairments as well. And then, yeah, so then the consensus statement in 2018, it's really positive for conservative management, which is fantastic for us all. So, you know, our young and middle age adults with hip pain, exercise being the first base of treatment, or the first point of treatment. So, and targeting the impairments and the dysfunction. So really looking at the lower extremity and trunk muscle strength, motor control, and also, again, like focusing on dosage and progressing. So, you know, not just focusing on, 10 reps, 3 sets on low resistance. We need to be upping the ante and really progressively loading this population up so that they can return to the high activity that they'd like to get back to. Yeah, and then also like really having that conversation about the expectations of how long these sort of conditions are going to take, because it definitely is not a quick fix by any stretch of the imagination, and it's because we're dealing with impairments that are movement impairments and just weakness. So we know to get good strength changes, it takes an absolute minimum of 6 weeks. But really to get longer term changes, it takes 12 weeks. And then that's with a quiet, unirritated joint. So often in the preamble of getting some changes, we need to, calm it down and get it quiet and not sore, and start improving just some gentle load capacity into the system. And then once we've kind of got a quiet joint to work with, then we're off and running in that 6 to 12 week mark. But sometimes, like I've got a young teenager at the moment, and we've probably been at it for 5 months. And it's, again, like not all patients are textbook, because, she plays soccer for one term of school, and then she'll play hockey for the next term, and then add in dancing and all of that sort of stuff, and then add in a few lockdowns and reduced ability to come in and do a rehab and all that sort of stuff, and we're going to get it pushed out. And then obviously you're dealing with a growing body as well. So a lot of the times it can take 12 months to get these things underway. And I think having that conversation is really important. And I think also having that conversation where we'll often find that, so we'll often do the HAGOS and the IHOT outcome measures. So that will be more our subjective findings. And so often we'll find that they'll still be reporting pain, and pain won't change that much in the first kind of 6 to 8 weeks. And so they really have to kind of trust us that we're onto the right thing, because it we'll get them stronger. So this is where our handheld dynos really work nicely, because we can show strength improvements, and I'll tell them, like, you'll get stronger over the next 6 weeks, but your pain will probably stay about the same, but your function will be improving, but your pain levels will be about the same. And really it kind of does balance out, because you're functioning better and you're performing higher and your pain has stayed the same. But then it's not until we go to the next stage where we get you that little bit stronger, then your pain's going to start dropping away as well. So I think that obviously keeps them a little bit more motivated, and they don't get so disheartened when they still got pain or they have a little bit of a setback. It's understandable. And we still want this general population to be, doing general exercise. And it really kind of, I think FAI, especially in the footy population, it's got quite, famous, but really I reckon the biggest population that I see this in is kind of your 35 to 55-year-old women. And so often it's just, general exercise is really important for them to keep on going and staying as physically active and meeting the physical activity guidelines to maintain their health and wellness is really important. And just, really making sure that we're discussing our realistic expectations and it being a shared decision, because obviously this sort of treatment plan is pretty involved and it takes time, and they need to know all of these things up front. So yeah.
Can I ask a question?
Yeah.
The dynos, regardless of presentation, will you use them on every patient as a baseline, or
I would, yeah.
you with that?
I would love to, but the answer is no. So here's I've lost myself out of your screen here, so I'm not sure what you guys can see, but there we go. But yeah, so this is one of the cells that we use, and it hooks up to a little tablet, and so it's got the graphs and everything like that, which I'll show you in a second. But no, we don't use it for every single patient, but we definitely use it for a lot of presentations, and there isn't a hip that comes in that I don't do it with. And I'll often do it with like knee patients too, a lot. So yeah, so I guess I've got my favorites that I use it with, but yeah, hip patients, knee patients, shoulder patients, I'll be using it very regularly with, because yeah, and patients love it because they kind of like, it reinforces what they're already feeling, that they've got, you know, the reason why they've got pain on that right side is because, you know, they can only push 4 kilos versus 15. Or they've been doing their program for the last, you know, 4 to 6 weeks, and they've improved, and they're now at 8 kilos, and they can feel that they're getting stronger. So again, it just helps with that motivation, and knowing that they're on the right path, and being, you know, it improves their autonomy. So yeah, so that's yeah, I find that that's really helpful from that perspective. But yeah, we've got the Axit system, but you can get just these little handheld dynos that give you an instant number. And I've often thought that we should have one in each drawer so that it's just that quick, easy, just use it for your assessment straight away.
Yeah.
Before we go on, have you guys got any other questions? I kind of prattled through that very quickly.
No. Yeah, the only other question that I had, Amy, was we see a lot of glute med tendinopathy and trochanteric bursitis.
Yeah.
Going back a few slides to your functional assessments and range assessments, are there any common deficits that you see with either of those presentations when it comes to the strength test or the range ability?
Yeah, range is really unpredictable. Sometimes range can be down a little bit, especially with, I often find with that like flexion, abduction, external rotation, with putting the opposite ankle on the opposite knee and just letting it drop, that can often be really quite provocative. But really for glute med, it's palpation over the tendon, and palpation through the glute med min. And then from a functional perspective, I'll get them standing on one leg and look for the a Trendelenburg sign, and then get them doing a single leg squat, and then it will obviously be really exacerbated. And then looking at, from a strength perspective, I'll just get them in side lie and do a manual muscle test into abduction. And often I can just push them down with one hand, and then they'll often feel a difference left to right. And then sometimes I'll do like a bridge as well, like a single leg bridge. And often they'll probably cramp in their hamstring because their glute max has gone on a holiday and doesn't want to work. But so yeah, so that's kind of how I differentiate that. It's really kind of definitely the posterior, like, you know, it's more that posterior lateral pain, and they'll kind of be grabbing around that area. But yeah, but that can get also like pretty murky and tricky, because obviously you can get a little bit of posterior hamstring referral, and sometimes you can have a bit of both, and sometimes I think you just have to pick a lane and clean that bit up, and then the next thing will unveil itself to be an issue. And I'll often talk to a patient about, sometimes it's just layers of the onion, and this is causing you the most amount of pain at the moment, and so we're going to calm this down, and then we'll reevaluate and go from there. And I think that works well. I think that if you're just honest and you have a plan, I don't think a patient needs to be handed the exact deficit or diagnosis that you've got, but they need a meaningful diagnosis and a meaningful plan. And so I think that helps. My only other caveat on that would be sometimes you're banging away on this, like obviously glutenopathology is an overload. And sometimes, with the really persistent ones, so I did it with a runner, and I was looking at him running, and it's like, oh, like you've got bilateral hip drop here, and your technique's pretty messy. And then I did the strength assessment on him, and my bias would have been, or was, your symptomatic side is going to be your weak side, but his symptomatic side was actually his stronger side, and his weak side by a whole heap was actually his non-symptomatic side. But again, that makes sense when you're dealing with a runner. He's offloading his weak side and then loading more on his symptomatic side, and that's causing the pain. So everyone had been treating his say his right leg and not getting anywhere, but we hadn't looked at his left leg, and really, like, it was his left hip that was the problem. So I find that it's helpful from those perspectives. Any other questions? Did I kind of answer that, Sol?
Yeah, that's perfect. Yeah.
Cool. So I am going way under time or over time, I think. So I'll try and rip through this and get to the meaty bits that are best. So this is a case study that came in, 36-year-old female, anterior hip and groin pain, right, worse than left. Also had some lower back pain because it's always messy and not just as simple as it comes. Running was worse, walking was worse, sitting was problematic, and sitting cross-legged was problematic. Mother of 2 young kids, working from home and studying as well. And then, activity was trying to get back into running post kids. No history of gyno issues and no history of cancer, and nothing too nasty that I was worried about. So her theta was positive, ER was fine, flexion range was fine, but resisted above 90 was a bit problematic, along with adductor squeeze, and theta was positive. So again, like, we're just not in nice little textbook silos. And then, so palpation, adductor longus was sore, and she was still sore, glute med min, and psoas was sore as well. And then functionally, double leg squat, she had a slight valgus and that anterior trunk lean. And then, single leg hip drop and increased valgus. So just that quintessential movement pattern that we know is going to possibly cause a problem when you load that repetitively. So I did some strength testing with her. So globally down, so abduction, adduction, the ratio was way off. So we're wanting an abduction and adduction, again, in a general population of 1-to-1. In your soccer players, it's going to be higher with adduction again. And then, hip flexion and hip extension was really down. So, like, when we're looking at our asterisks of what we're going to get a big bang for our buck is we're looking at adduction and extension. And then obviously abduction was down a lot, which hopefully you can see here. So here's a little video of me just doing the tests this morning. So it's super quick and easy. The thing that you're not seeing is the tablet, but the tablet then produces these graphs. So then you can obviously show it to your clients. But she's got, 8 kilos pushing through the right and 7 kilos pushing through the left, so a discrepancy of 18%. And again, we're wanting that to actually be 15. So we know that she's weak and down a lot from the norms that we would like. And then adduction is another big deficit here. So she can only push 4 kilos. So yeah, so really light on, especially when you think about the fact that she's wanting to run. So whenever I'll kind of run through this, but essentially by doing that assessment, it kind of gives you a clear indication of where we're at. She wants to be a runner. And so now we need to go, okay, well, here are our big asterisk signs, and these are the things that we're going to implement with packing out your program, because we need to get you back to being able to do all of these athletic tasks in your everyday life. So first, we kind of think about more your movement control. So you're doing more that neuromuscular retraining. And so I'll just run through these exercises. So here I'm doing what's called a skater. And so the stance leg is working the hardest here on a light spring. So I'm really loading up that right stance leg, and I'm getting that nice lumbopelvic control. Same here with the scooter. When it's light, we're working on the stance leg, and again, that lumbopelvic control and endurance through the stance leg. If I start loading that up, and that's what I will do as I progress with the rehab, we'll kick out and hold. And again, that's working more of your extensors and your external rotators, obviously. And then, starting to mimic a little bit more single leg work. And that's obviously a progression. I think my patient now has this on her second or third program. So let's go to the next one. And then, getting some, some trunk work and some lateral trunk work going. So some side plank work and some icebreaker. So like working on the anterior sling, working on the lateral sling, or the oblique slings here, and getting some strength going from that perspective. And then integrating some S&C work once I'm happy with movement pattern. So then we're going, squats, deadlifts, side planks, getting the Copenhagen's going with their adductor work, lunges, and then heel raises and pull off presses for abs and going from there. And then, so then these are her progress, or our milestones and checkpoints, to make sure that we're heading in the right direction. So the little graph down below shows different times that we've tested. And you can see that, she's made improvements of 43% on the right and 61% on the left. It's still down in her adduction, but nowhere near as much as what it was 4 earlier. So she's, doubled and improved. And then abduction, again, we're kind of just been pretty stable with that at the moment. And then working on hip extension, again, we're improving 34%, 54%, and the track's going upwards. But again, I want hip extensors to be a lot stronger than that. So we've still got a ways to go there. And then, knee extension, through her quads, she's quite good and quite dominant, obviously. And you can also see, her knee flexion. So her hams are down a bit. We'd like them to be up, but they're making good progress, as you can see. And her hip flexion, we actually haven't done anything to her hip flexors really yet. But again, they've made some good improvements as well. So, so now she's, obviously she's not there yet, but she's making good progress, and she's back to running 2-3 times a week at about 3 Ks. She's doing her home exercises. She's now reintegrated back into our 2-on-1 outdoor Pilates, and she can sit now without pain. She can walk without pain, and she's running without pain now, which is good. So it's kind of like, this is just a little summary slide of how we go about things, and it's pretty simple. Just calm things down, improve the way things move, and then load them up, to a more sport specific functional ability with more like your power, agility, and return to sport tasks. And then obviously when we're dealing with an athlete, we want to implement some injury prevention work. So that's it, guys. I got in there with 2 minutes left, so so anyway, I probably rushed through that towards the end. Do you have any questions about any of that rehab work, or any other questions about anything?
Can I just ask you a question about some of your strength testing stuff that you're working on? Obviously, the symmetry and the global strength is both really important, but do you prioritize one over the other? Like, usually what we work on in here significantly is definitely the symmetry part of it. We do a bit of rehab stuff, but a lot less than you guys do. But which part of it is sort of prioritized in your rehab plans?
Yeah, so I think it's not often that I go just do this side, but I think by improving, like I'm working with a person at the moment that, we need to do some sling work, and I'm only doing one-sided with her while we just kind of bump that up and kind of plateau it and normalize it. And so that will kind of be for a couple of weeks, but then we'll be going, okay, well, let's make this symmetrical now and load it up. So I think once we're kind of calming down the movement pattern, and the movement pattern's good, then I'm kind of looking at strength work. Like if I was to deal with a shoulder, like I just, work pretty unilaterally. But yeah, did that answer your question, Jack?
Yeah, thanks. Yeah, we've never seen those little cool little things with the force plates. They're fantastic sort of things for patients. Yeah,
they're amazing. They're really, really good, and it just helps. It kind of validates what the client's feeling as well, and then obviously by rechecking it, it kind of gives that reassurance that we're on the right path. So I think like it's quite helpful for me as a practitioner, but then also for the client too. They get really, I think sometimes they hold their breath while I then tell them the answer because they really want to improve, obviously. But they're really good.
That's great. Thanks.
Anything else, guys? Do you guys see much FAI in the clinic?
Yeah.
Heaps?
Yeah, quite a bit.
Yeah, for sure. I think it's a pretty common condition, and I think I think surgeons are operating on it less, which is good. But obviously something that we really have to manage well, because it does have a high incidence later on, or a high prevalence of contributing to OA, and having an early OA finding. So we want that hip to be nicely in centered in the joint as much as it can, so it's not sliding around and having that imbalances causing the synovitis and causing the cartilage damage, and go from there. So it's a really manageable, well managed condition once people are on board with it, for sure. Yeah. Any other questions for me, team?
No more questions, but that was great, and it was good to go through a lot of that objective science evidence side of things, which I think that's certainly a strength of physios, and something that us as osteos can probably take a little bit more on board. But I think, one of the key things, just listening to some of your language, there's a lot of crossover in terms of that human element and the support and how you motivate a patient and encourage them through that process. So I think there's a lot of similarity in terms of that side of the approach.
Yeah, 100%. And I think none of us will do our job very well if we don't have that communication aspect and, understanding where the client is at and where they want to get to, and, de-threatening their pain, because everyone comes in worried. And so as much as we can give reassurance, I think that's probably the number one value that we can give our clients, is that reassurance and that plan. And and then we'll obviously get good outcomes.
Yeah, for sure. Yeah.